Good morning, everybody, and welcome to the Tech-Enabled Virtual Ward Experience. This is a series of how-to webinars that we're running, talking about how a number of sites, and we're starting with hospital sites, have used technology to really help support patients with COVID-19 at home. Delighted to have for you today Matthew Knight. Matthew Knight is a consultant respiratory physician at West Herts, and his colleague Alex Newland-Smith, who is a chief respiratory physiologist also at West Herts, who are going to talk about how it was for them. We also have joining us Chris Richmond. Chris is part of my team at NHSX. He is the head of delivery in the innovation team, and Lisa Hollins, director of innovation. I'm Tara Donnelly. I'm the chief digital officer at NHSX. And I have to say, working with the teams on this project has been a complete joy. It's proceeded at great speed, and they've been fabulous colleagues to work with. The way we've briefed them is to talk to you about the experience as honestly as possible and give really useful nitty-gritty details, as though they were going for a cuppa with a long-standing colleague who's really keen to put in a virtual ward that's tech-enabled in their organisation. You will see that cups of tea and pots of tea become quite critical to the process that happened at the West Herts organisation. And the bulk of the session will be Matthew and Alex talking about how that worked. I'll then come in and talk about some resources we've developed to help support people who would like to adopt this model, and then we'll open it up for questions and answers. So please, as we're a really good number today, we would love you to, as the presentation unfolds, just add questions into the chat. You can also vote for questions. If somebody asks a question that you think is particularly good, you can give that the thumbs up, and we will select the most popular and put them to our panel for the final session of the webinar today. So that's really all I wanted to say by means of introduction. Oh, just one final thing is to say that the work in West Herts used a particular digital platform which worked well for them. This was Meadowpad, who kindly made a pro bono offer as part of the COVID-19 response. There are a range of products available, and we'll be talking about that towards the end of the presentation. So that's it from me. I'm delighted now to hand over to Dr. Matthew Knight to tell you about the West Herts experience.
Hey, good morning, everybody, and thanks very much for handing over, Tara, and introduce my colleague Alex Newland-Smith, who works closely with me and runs our respiratory physiology department in West Hertfordshire. So a little bit about us. We're a district general hospital based on the sort of northwest edge of London, or I get told off for saying we're on the edge of London. We're in Hertfordshire, and we cover a sort of a mixed rural and city-based or town-based sort of population. Have some high levels of deprivation within our local area, as well as two of the highest areas of tax evasion in the United Kingdom, according to yesterday's Telegraph. So it's quite a mixed socioeconomic area and quite a mixed age group. And we cover a population of 650,000 head of population. We're a hospital that sort of the first part of the 21st century, I think it's fair to say, sort of passed us by really from an IT perspective, and we were still running not just Windows 7 machines, but even Windows XP and one computer which carries on Windows 95 down in the outpatient department. So we're not a sort of a high-tech sort of 21st century hospital with the best IT in the planet. And I sort of set that as the scene. So you can see pretty much anybody can run virtual hospitals or virtual wards within their setup. My own interest is I'm a chest physician with an interest in unexplained breathlessness and out-of-hospital respiratory medicine, and have a passing interest in sort of IT and technology. Alex, do you want to say hello to everyone yourself as well?
I'm Alex Newland-Smith. I'm a respiratory physiologist based at West Herts. Normally, in normal times, I run the respiratory function department, primarily doing diagnostic testing. The role has changed this year, and got involved very heavily with the virtual experience with the virtual wards that we ran from sort of March onwards. yeah, have suffered the delights of our IT for the last 10 years. So it's been an interesting year, and amazing to see what we can do with decent technology.
Can we go to the next slide, please? Okay, so just to really sort of set the scene a little bit, what we will and won't be talking about and what we did and didn't use. As such, all of the technology that we rolled out was all to try and sort of what we called sort of extend the human, really. And I know Chris is very keen on this term, but it was a key concept to us. We had a large number of patients who were scared, as were we, I think would be pretty honest. We were anxious about the impact of COVID. We were anxious whether the hospital would cope. We were struggling to cope with the winter as it was at that stage before COVID hit. So we wanted, before we did anything, was to be able to provide reassurance and compassion to our patients and care to our patients. That was sort of the underlying sort of drive for everything we did, really. So the things we're talking about when we're talking about technology in this talk are remote patient monitoring, in essence. So gadgets that patients can use at home to provide estimation of physiological parameters or communicate symptom scores and well-being, or an absence of well-being, to their consultants or other clinicians. Telemedicine consultations and virtual consultations or virtual messaging sort of apps. We didn't use any machine learning or artificial intelligence or any sort of robots or any Star Trek type sort of technology in what we were doing. We are planning and are starting to roll out more point of care technology though. So we can go into the next slide, please. So the main sort of aim really, as I said, is to reassure patients, to make them feel that sort of human contact, to improve clinicians' efficiency. And when you'll see how we originally ran the virtual hospital, you'll see it was quite clunky. To direct clinicians' time to those most in need of care. Out of the 1,500 patients that we had, 8.4% I think had some sort of complication associated with having COVID. So over 90% didn't, and we really wanted to try and make sure that we focused our attention on those patients who were the sickest, without ignoring or neglecting those patients who still needed support, even if they were not so sick. And to improve collaboration and team working, we used quite a large multidisciplinary team. We had respiratory physiologists, orthopedic physiotherapists, a fourth-year medical student, a couple of house officers, respiratory consultants, geriatrician, a cardiologist, and an orthopedic spinal surgeon at one point involved in our virtual hospital team. So there was a range of skill sets and comfort zones, and we needed an easy way of each collaborating with each other. Go to the next slide, please. So, overview of this talk, we're going to look through some of the drivers for change at West Herts, which are probably similar to the drivers but not identical to those in each of your locations. The virtual hospital journey, how we evolved, our clinical pathway, which in essence is the same as when we started. Alex is going to talk a little bit about saturation probes and some of the technology behind them. We'll present some of the high-level outcomes from the virtual hospital, talk a little bit about Meadowpad and how we used it, and really how that was a bit of a game changer towards the end of wave 1, and will certainly be a very significant part of our wave 2 response. We've already seen a slight uptick in the last 24 hours in the number of referrals into the virtual hospital. And then some points on how to plan a virtual hospital setup locally, hopefully to stimulate some discussion. And we're hoping that there'll be a good amount of questions and answers and discussion at the end. Can we go to the next slide, please? Next slide. Sorry that I'm asking someone else to move my slides, and I'm currently based at the University of Valencia, so I'm overseas at the moment, so it's doing some teaching and research. So I'm really pushing remote working to the extreme. So go through some of our drivers for change. We were already on a very slow journey to incorporating more digitalization within our referral pathways, both in the inpatient and the outpatient setting. So in 2017, there was an acute appreciation of the need to change the way we managed acute medicine. We rolled out a number of respiratory hot clinics. We were already running plural clinics on an outpatient ambulatory basis. We started an acute inreach into the acute medical take called SMART, which delivered respiratory consultants and cardiology consultants right to the front door. That's evolved into becoming a virtual sort of consultant to the front door. So we're now wheeling consultants around on trolleys in sort of Lord Darzai fashion to where they're needed rather than where the consultant happens to be. So we were already on a journey to doing some of this. In 2019, in the outpatient setting, we had a trial of virtual clinics and used a specialist electronic referral management platform called Meadowpad to help us triage our outpatient referrals. And this resulted in improvement in our RTT and new to follow-up ratio, improved understanding of referrals, quicker access to subspecialty clinics, improved access to clinics for people who wanted to have virtual telemedicine type clinics. But next slide, please. But I say that we were very much sort of stuck in the technology slow lane, really. We're not going anywhere that quickly at that time. And then, of course, COVID came along and really sort of sped up the sort of the imperative to change quite rapidly. So I guess the key date was 9th of March. I remember this was in my diary. We had a get together around the dining table in my house with a few pots of tea, some pens and paper, and we basically came up with an action plan for managing COVID out of hospital in as safe a way as we thought we could. We'd had a review of the literature as was at that time, settled on a few clinical parameters and a bit of structure, and accepted our first referral on March the 13th. And we've had 1,500, I think it's almost 1,600 referrals now come into the virtual hospital since that date. If I'd uploaded this with this morning's figures, you see that line on the right slightly, I don't know if you can see my mouse here, but it's slightly starting to go up quite worryingly, having had a rather nice number of daily referrals for a few months now. So I'm hoping we're going to avoid this, but we are starting to see an increase. Can you go to the next slide, please? So our clinical pathway, which we scoped out at that time, has remained pretty stable ever since we launched the service. So referrals would come in. So if you look over to the left, and I'm sorry, you can't see my mouse on this, but as you look over to the left, referral sources were mainly from A&E, the medical take. We had some referrals from microbiology directly and some referrals from the occupational health department. The entry criteria was pretty relaxed. You had to have saturations of greater than 92% at the time of entry to the virtual hospital. You had to have a heart rate less than 100, although we've slightly relaxed on that now. We go up to about 110. A CRP less than 50 at that time, although as our evidence base has improved, we now take anyone with a CRP of less than 70 at the time of entry. We don't mind a higher CRP if they're an inpatient and the CRP trend is coming downwards, but certainly if they're from A&E, CRP of 70 was our sort of cut-off now. But when we started, it was 50, and a NEWS 2 score of 2 or less. And patients had to have access to a telephone. It didn't need to be a mobile phone, but it had to have some way of communicating with us and to be able to self-isolate and self-care. So we were not able to provide physical care at home if that couldn't be provided in some other way. And in essence, what happened is on the very next day, so day one, and in the virtual hospital, the referral was reviewed by senior clinicians. So at the beginning, that was a consultant, and very rapidly that included senior respiratory physiologist or senior physiotherapist at band 8 A level. And the history, a patient was telephoned, a more detailed history was taken and an understanding of their comorbidities, and patients were triaged into 2 groups, a low risk or high risk. And in our service, you had to work very hard to get into the low risk group. I mean, you had to be a young, healthy gym goer with no medical problems really at all. If you had any medical problem on any medication, pretty much never been in hospital, you automatically got put in the high risk group. The high risk group was anyone who was 50 or over, any comorbidity, from an ethnic minority group, a healthcare worker, or where the clinical assessment prompted the clinician to be concerned about the patient. And the difference between the high risk and the low risk pathways were about the intensity of the follow-up. The low risk pathway was a call on day 1, 7 and 14 with safety netting advice. The high risk pathway was far more intense. So patients got calls on day 1, then day 2, 3, 4, 5, 7. We changed the day 10 call to a day 9 and 11 call eventually, and day 14 call and beyond if needed. And patients were all given a saturation probe if they didn't have one already. We had large numbers of saturation probes. We purchased those quite early on, and they were a key enabler to us being able to run this service. And the daily consultation was done primarily by telephone, although we used Attend Anywhere and other video sort of conferencing type facilities for patients who were able and willing to use those. Can we go to the next slide, please? And whilst the service grew quite substantially, the key resources just to getting going were 2 consultants to provide a 7/7 service. And Alex joined us, I think, at the end of week 2, if I remember correctly. So we became a team of 3 pretty quickly. The telephone, we needed a way of knowing who we had to call, so we had some admin support to create patient lists. When we started, this was an Excel sheet on a shared drive, which was clunky, but it did the job. We now have an electronic patient record, which has its own benefits and its own problems, but IT department worked hard to get that developed. But when we started out, it was pretty simple. It was an Excel sheet generated list, and we had a list of patients to call, lots of saturation probes. An escalation pathway is crucial, really, to running a virtual hospital safely. So for us, that was a dedicated pathway via the acute medical take for patients who were suspected or had confirmed COVID-19. It could be via a GP hub, it could be via the A&E directly, but you need to have a way where you can, without discussion, access an escalation pathway. Most of the patients we brought for further input were mainly for further imaging, CT scans, X-rays, bloods, and so on. Very few did we admit for any lengths of time, but you need to have that pathway in place and agreed. You need good governance, so we had our clinical director, medical director, and the exec team sign off on this pathway early on. For us, one of the key resources was a patient grab pack, which I think we got a whole load of child slave labourers such as Alex's children and others to pack these things. Could you go into the next slide, please? But in essence, this was a sort of like a party bag, as it were, in A&E that could be given to all patients who are being discharged, which had inside it a saturation probe, a number of temper dots. For love nor money, I couldn't get hold of thermometers at all. I mean, on Amazon at the time, it was like £200 for a thermometer, and so we couldn't get hold of those. But temper dots were a very low-tech solution for I'm sure most of you will remember them as kids, or using them on the children were younger, so go under the tongue or under the arm, and a minute later they change colour and tell you the temperature. And we found those a very reliable low-tech solution to the absence of thermometers at the time.
Also a lot better than a lot of temperature readings that people had at home for their own children. I mean, we yes. found ours early on were not good enough, where temperature dots were fantastic.
Yeah, so we ordered those in and put them in the bag, so people had them to do their temperatures at home. Certainly better than these funny thermal cameras as well. A number of masks, just in case we needed patients to come up. It was all before the face covering campaigns were gaining any traction. And patient information leaflet. And I say getting your information leaflet right is really crucial, because you need to manage patient expectations about what you will and won't be offering. So for us, that was a 9 to 7 service, 7 days per week at that time. But you needed clear signposting for patients about what to do if they got sick in between telephone calls or in between contacts. So for us, that was the local GP hubs, 111, 999, or direct attendance at the COVID A&E at that time. So information about COVID, our physios put information in there about airway clearance, and we had information about how to use a saturation probe, including links to videos from Health Education England online for those patients who were web enabled. Can we go into the next slide, please?
We also had the addition later on of the QR codes for people to directly download the app and the videos.
Oh, yes. So oxygen saturation probes, I'm going to hand over to Alex in a second to talk a little bit about these, but these are obviously key. They're a key part of the NHS England guidelines for community care for COVID-19. And if you haven't downloaded them, I've put the link here. I'd suggest you do. That it's a great document Matinada Kim and colleagues have put out after much discussion. Can we go on to the next slide, please? And I suggest you download both the document and also the patient diary, which wasn't available when we ran our COVID virtual hospital during the wave 1, but is now available, and is a very useful tool. This is the national pathway for managing COVID-19. We bundled the moderate and severe groups into our high risk groups. We had the backup of a whole hospital. This is more designed for GPs running services, and there is a slight difference that I could obviously arrange a CT scan and still send the patient home if there wasn't a PE or there was no concerning pathology. We could get an echo the same day if we needed to. So we had access to a lot of tests. So the hospital was a very fluid concept here, and the mild patients tended to go into the low risk pathway. So going to the next slide, please, Alex. I'm going to hand over to you to talk a bit about SATS probes and how they work, how they don't work, and why you shouldn't be using phone apps.
Well, absolutely. Well, oximetry works on the principle of the differential between oxygenated hemoglobin and deoxygenated hemoglobin. They work by shining two sources of light, an infrared and a red light, through the finger onto a receptor on the other side. The oxygenated hemoglobin will absorb more infrared blood and deoxygenated red light. There are lots of factors that can influence the quality of your signal, but the principle of AC versus DC light absorption is how we sort of eliminate a lot of the issues that happen with the other tissue around the finger. With the virtual hospital, we were using fingertip probes. Oximetry can be used in all sorts of other places, but for most people, fingertip probes are the best, easiest thing to use. They're not without issues. You've got problems with poor peripheral circulation, poor signaling, just simply cold hands, and spending a little bit of time showing a patient how to use an oximeter was very important, and making sure that they were measuring oximetry at the right time was absolutely critical. We wanted readings at rest, and then we sort of go on to do a little bit of exertional monitoring in hospital, either with the 40-step test or a sit-to-stand test. Most of the commercially available oximeters are absolutely fine for use. It's very important that they're accurate within 2%, between 70 and 100%. Readings below 70% oxygen saturation are not reliable. It doesn't matter how much money you spend on your oximeter, but for COVID, we were looking critically at around a 92%, where we needed to potentially see patients in hospital again. All sorts of other factors that, abnormal HB, so that, if you do have either polycythemic or anemic patients, can impact on the saturation readings you're getting. Carbon monoxide poisoning will give a high oxygen level. But talking patients through, showing them, we had the letters in the grab bags that had the links to videos of how to perform oximetry well, and talking them through on the phone was in our daily calls, was getting the oxygen levels at the right point. Can we go on to the next? Is that still? So the key clinical measures we were looking at were saturation at rest, and that's what featured mostly in our daily calls. And having an objective measure with patients was really critical, because most people felt pretty rubbish while they were, so even if they weren't critically unwell, they felt pretty poorly. The reassurance it gave you of having a normal or near normal oxygen level and heart rate was a really fantastic addition to a call where you're not physically got the patient in front of you. In hospital, we were doing the sort of sit-to-stand test, where a patient quite literally sits and stands as many times as possible in 1 minute. There are limitations with mobility and frailty. It's certainly not worth finding out someone's desaturating on exertion if they break their hip. The saturation over 40 steps, traditionally that's done up a flight of stairs. In this case, it was on the flat. Really, we were looking for desaturation of more than 3% as a indication that someone's not well enough to be monitored at home. And is that what's on to the next? And then there's an excellent sort of guidelines, partly written by Dr. Knight, on exertional desaturation. Can we link to that on here?
Yeah, if you just type efficacy and safety of rapid exercise tests, you'll find it's on the Centre of Evidence-Based Medicine.
It's key to put the sit-to-stand and the 40-step test. Neither is ideal at measuring sort of desaturation in patients. Traditionally, in a lab, we do either a standardised 6-minute walk test or shuttle walk test, or for a more complex patient, move on to cardiopulmonary exercise testing. But it's something that's easy for patients to perform. Potentially, you can do remotely, but I wouldn't advise having sit-to-stand tests in an unsupervised way.
Yeah, and we sort of, I used 40 steps quite a bit around the living room, or even just standing still if there was another person in attendance. But if a patient was genuinely at home on their own, I think it's best avoided to do too much exertion. but the 1 minute sit to stand we've done entirely in the hospital base. There's currently 3 studies, 2 have written up and 1 that's just about to start, looking at the role of 40 steps and 1 minute sit to stand. So we'll have a better evidence based around that in the coming months. But provisional studies have sort of endorsed Trish and Babette Mine and Matt Inada-Kim's initial review of the role of these tests in COVID-19. Can we go into the next slide, please? So a little bit about the resources used. Next slide, please. So at the peak of the pandemic, which I've sort of forgotten when that was, but around sort of April, I think, mid-April for us, we had around 400 patients managed simultaneously, because all the patients stayed with us for 14 days. A lot of them were on the high-risk pathway. We had 3 full-time consultants providing morning and afternoon commitments, 3 part-time consultants, each providing half-day every day of the week, 6 days per week. And between us, we provided a 7/7, 9 to 7 service for most of the pandemic, and certainly the entirety of the first wave. Had 3 respiratory physiologists, again working full-time, 5 physiotherapists from the orthopaedic department, spinal rehabilitation unit, each providing half a day of commitment. Quite a support, so 1.5 people every day, Monday to Friday, and then half a person, as it were, just a morning on Saturday and Sunday. And we had 2 shielding FY1s who were both pregnant, who I was a bit reluctant about taking. However, they really came into their own. They were great. Plus a lot of interface with community team, palliative care teams, district nursing teams, primary care teams through the hubs that started to open up. So it's quite a hefty time commitment. Going on to the next slide, please. And the first 900 cases we audited in depth from March 13th to May 13th at referral date, that is, and it was just over an hour of clinical time over the 14 days of follow-up per patient, and each call was about 8 minutes with a bit of admin time. Next slide, please. So this is not an insignificant amount of time commitment, and just for those who are interested in the sort of the mix of patients, so again, I've gone through the first 900 in a lot of depth. Half were from A&E directly, half were discharges from the ward with short admissions, so 70% were admissions 48 hours or less, and most of them were with admissions 3 days or less. Of those 900, 18 died, 2%. 16 of those died in hospital from following a readmission, and 2 had supported care at home. They were aged 93 and 92 and were already known to community palliative care services. A total of 8.2% of patients were readmitted. A lot of those readmissions were just attendances for CT scans or echocardiograms, and they were less than 24 hours, in some cases less than 12 hours, but we've put them there as an undesirable outcome. However, that fits well within the same-day emergency care guidelines from NHS England, suggesting 10 to 15% of patients in an SDEC pathway would expect to be reattending. Average age was 55, average number of comorbidities was just over 2.5, so between 2 and 3. 60% had abnormal chest x-rays, and 30% were by definition hypoxic. They had low saturations at the time of referral. So this was not a well and healthy young sort of 25-year-old gym goer with no other medical problems at all. There was quite, patients were of a certain age with a certain number of comorbidities, and we managed to manage them, I think, safely and effectively. Next slide, please. But we were getting pretty stressed out. I think by the Easter weekend, we had one day when David Evans, myself and Ross Kings had to call between us coming up to 130 patients on the high-risk tracker, in addition to the patients on the low-risk tracker. And we were already chatting with NHSX at this time about how we can use technology to help reduce the workload, because it was an unsustainable amount of work. We were, in theory, doing 9 till 7, but we were doing 12, 14-hour days, as were colleagues in the front line in the inpatient unit, and all of whom needed to have some relief that only we could provide to them from the workload. So we needed a way of sort of managing the same number of patients with less time. Can we go to the next slide, please? So, and I sort of compared it. I'm not particularly into fishing, but my father-in-law is heavily into fishing, and I was amazed at how technology is heavily involved in something that seemed as simple to me as catching a fish, which is not that simple at all, it seems. But there's sort of 2 ways of doing this. You can throw out a net and hope that you catch what you want, which involves a lot of catching of things you may not need and a lot of sorting. Or you can use a radar, and a lot of fishing boats now have sonars on the bottom, and you not only tell you the depth of the sea below you, but also what's below you in the context of fish and how big they are, and you sort of go around catching what you need. And I thought this analogy was quite important. What we needed to do in the virtual hospital was that we needed to provide care and attention to everybody, because people were worried, they were anxious, they needed reassurance. So I didn't want to take the human out of those interactions, but we didn't really need to phone a patient every single day for them to tell us they were getting a little bit better and their oxygen saturations were fine. We needed a way of reducing the number of telephone calls, but not reducing the safety, and knowing instantly when a patient was deteriorating so that we could act pretty quickly. Can we go to the next slide, please? So here came in the Meadowpad app. There was an awful lot of work from Chris and colleagues. Chris is the face of NHSX for me, and literally the face. I think every day for a period of time we had our 10 o'clock meeting, didn't we, Chris, in the morning from my study and your study and various places. But it was an immense amount of work went in to work with Meadowpad Huma to bespoke an app that was already being used in, I'm going to say Germany. I think I'm right with saying Germany. But in its essence, it's a communication app that allows patients to collect and transmit data about symptoms and physiological parameters, so oxygen saturations and heart rate in this case, to their clinicians, and for the clinicians to acknowledge the receipt of that, so that patients know it's been looked at, and in effect communicating back to the patient that the clinician knows. So if you don't get a call, it's because things are heading in the right direction. Patients had a phone-based app they needed to download onto their phone. Clinicians logged into an online portal, or still log into an online portal, and review patients who are RAG rated. And clinicians can either through the app to conduct a telemedicine consultation. Most of the time, most people just preferred the telephone. A lot of patients didn't really want to see me from their bed. They certainly didn't want me seeing them in their bed. They were quite happy with just having a voice chat over the telephone, but it was useful to have the telemedicine on occasion. I go on to the next slide, please. This is the patient's view. So this is taken a screenshot from my phone. And the patient is prompted once a day to load up detailed scores about their symptoms, and 3 times per day to load up a score about breathlessness, temperature, oxygen saturation and heart rate. For breathlessness, the score was 0 to 5. We went through a lot of debate about how you measure breathlessness. Alex won't like 0 to 5 because he'll like a very complicated St. George's questionnaire.
Absolutely.
But we needed something simple that was measurable. And one person is very severe as another person is moderate, but we found that the trend was pretty good. And then scores and all the other symptoms, fever, cough, breathlessness, muscle aches, anosmia. I don't think we had anyone put loss of consciousness in, but palpitations were quite common. Diarrhea was particularly very common. So symptoms got added in, and patients would then rate those mild, moderate, severe, or very severe. If you go into the next slide, please. So we rolled this out end of April, very beginning of May. This is a clinician's view. This is in the training dashboard, but you can see the first sort of patient on the top is someone who in the symptoms column has got 2 that scored red. So you hover over that and it will tell you what they are, or you go into the patient's record. 5 symptoms that were amber. So this is a patient who's got a lot of symptoms. Concerningly, they're very breathless. So they've scored breathlessness 4 out of 5, so severe. And their oxygen saturations are in the red, so they've gone below the threshold we're comfortable with. So that's a patient who's got new data and we need to be worried about. So clearly on that screen, I'm going to go to that patient first before I go to the one below who has scored green for symptoms and green for breathlessness. And their saturations and heart rate have not raised it or triggered any concern at all. Can we go into the next slide, please? And this is going into the patient's actual record. This is actually 2 screenshots merged into one, but as you go in, you can see the patient's breathlessness score when it was uploaded, their COVID baseline score, which has all of the details about are they a smoker, their social care, medications they're on, previous medical history and other sort of information. Their current saturations, if you click on those, you'll get the bit of the screen below, which can be displayed either as a trend in a graph, as I've got there, or listed data. Different people like to see things in different ways. And you have that for heart rate, Can you go to the next slide, please?
I think the trend data is the real exciting potential future application for this sort of app, you know, beyond COVID and using it for monitoring other long-term conditions.
Yeah, certainly. We had patients, Alex, who were very symptomatic, but actual fact they scored red for absolutely everything, but their SATs were completely fine, and you saw sort of a change in the sea of red to sort of amber to green as they became increasingly reassured over the telephone calls. So it was a useful way of seeing the trended data, and the absolute figures do vary from one person to the other.
The addition of the where the patients could see we reviewed the data, the two little ticks that was brought in early on in using Meadowpad, I think that was a really fantastic addition because it allowed patients to see that we were looking at the data and reduced anxiety. Yeah, absolutely. We had a lot of good feedback about that. So with the rollout of Meadowpad, we added an additional track. Can we go to the next slide, please? Pretty easy to see. Yeah, on this slide, thanks. That before we'd had high risk and low risk, and there was no halfway house really. With the Meadowpad app, patients on Meadowpad, they went down the Meadowpad track, and the difference was that in the high risk, which was the vast majority by the time Meadowpad came out, because GP hubs had opened, and a lot of the low risk patients were by then presenting directly to a GP hub and being managed entirely within the hub. The call numbers were pretty intensive, and by this time we were getting calls on day one, but then 2, 3, 5, 7, 9, 11, 14 and more calls for the sicker patients. It was pretty time consuming, and a lot of the time, around 80%, 90% of the time, it was confirming the patient was getting better. By day 14 they were pretty fed up with the telephone calls really, other than they were a distraction from the boredom of quarantine, and we were manually recording saturation data. It's all quite time consuming. In the Meadowpad track, we just had calls, the initial clerking, and then day 2, 7 and 14. And this resulted in about a 50% saving in the amount of clinician time per patient, but importantly allowed us to call a patient the moment they uploaded something that wasn't supposed to be. In fact, we registered Alex's wife, didn't we, one day, just when we were trying it out to see how it would work. And I didn't quite notice it was your wife when she uploaded her pulse after mowing the lawn, and I sort of instantly called on the app to Alex's to Mrs. Newland-Smith in the garden, sipping something, probably a glass of wine or something after mowing the lawn. After saying, "You're very tachycardic, what's happened?" And I realised it was the Newland-Smith household. So it was quite good to be able to react to the science, and we had a number of patients where deteriorating physiology was detected quite early. And then we had patients on the true low risk tracker. Can we go into the next slide, please? So we reduced the frequency of calls. We allow clinicians to respond rapidly to patients' deteriorating symptoms or physiological parameters. We had a number of cases where we intervened. Some things quite simple, like sending Diarrhea for oral rehydration to patients who were feeling a bit sick, sending oral antibiotics to patients who were getting more breathless, and it looked like they were getting a secondary bacterial chest infections. We had 4 patients who we proactively admitted because of deteriorating SATs even before they started feeling increasingly breathless. Can we go on to the next slide, please? And this is just sort of a picture view, so the slides have got a bit muddled, but a view of the symptom scoring trended. So this patient was a very symptomatic patient, so I've anonymized all their data here, but they started off with everything red. They were ill and very anxious about it, quite understandably, and by the time they were discharged, there was a sea of green, which was quite satisfying for everybody. Can we go to the next slide? But absolutely, they're not for everybody, and even at the peak of our enthusiasm for apps, we had about half, just under half of new patients going into the app and about half staying on the traditional telephone service. But this freed up enough time for us to be able to do both, so that everybody got the service they needed, so that we were still able to offer the full service to patients who didn't have smartphones or didn't want to use smartphones. So finally, a few words about the output from the virtual hospital. All of our patients who had confirmed COVID-19 went into a post-acute COVID clinic for follow-up, and that has been both a clinical service and also has guided a lot of our research activity out of the respiratory team. Other patients were followed up as required in respiratory or JM clinics or via the GP with follow-up imaging at 10 to 12 weeks. Reassuringly, the vast majority of patients with abnormal chest x-rays had completely normal x-rays on the week 12 imaging. Can we go to the next slide, please?
There's a few things we're rolling out at the current time. So we're starting to use some real-time monitoring, which is continuous pulse, ECG, saturation, respiratory rate monitoring through the safety net device. We've started already virtual specialty in reach. My colleague Dr. Jay Ratnam, I think, did Watford's first ever video linked post-take ward round last week. I was a bit jealous not to be the first one, but anyway, such is life. I really advise those of you looking at doing remote hubs where you may not have access to X-ray on the same site to look at the wonderful work that Andrew Walden and Joe Noonan and colleagues are doing down at Royal Berkshire Hospital in Reading. And here's a link to their website. They're using ultrasound, point of care ultrasound, quite heavily in the assessment of patients, and with ultrasound, as well as seeing pleural effusions, you can see in effect lung water, which allows you to differentiate between consolidation, infections such as COVID, heart failure, and a number of point of care tests. They're running courses both online and socially distanced face-to-face courses at the hospital. They've got a few courses coming up in October, so I really do suggest taking a look at their website and looking at the work they're doing. It's really when you do something and then you see someone else's stuff and you think, oh, I wish I'd done that as well. It's a great piece of work there, so do take a look at their website. And we're starting to look at more point of care tests, so CRPs, procalcitonin, white cells, USNEs, BBGs and BNP, to see if we can manage more and more patients remotely at the hospital. Can we go on to the next slide, please? So things you need to think about, I think this is more to guide discussion and questions about setting up a virtual hospital. What are your drivers? I mean, our drivers where we thought the hospital was going to get overwhelmed. We were worried about nosocomial spread of infection. We wanted to make sure we used a significant number of our staff that were isolated, or shielding as that became called. So those were our drivers. They may not be your drivers. Our understanding of the disease is completely different now than it was in March. So firstly, think about what is it you're trying to achieve. Who are your target groups? So outside of the virtual hospital, we also supported an inpatient psychiatric unit for elderly people with advanced dementias. We did ward rounds every day with a consultant psychiatrist in that unit, and out of the unit of 31 patients, I think only one was brought over to the hospital. We supported their care. All of them had COVID, their care in the inpatient unit there, but clearly posting each of them saturation probes wasn't what we needed, and the Meadowpad app wasn't what we needed for those patients. We had a more traditional sort of way of doing it, an MDT, in effect discussing each patient each day. So look at who your target group are and look at what's suitable for them. Who are your available staff and skill sets? We were quite a heavily respiratory based team. We had 14 consultants and quite a large group of junior doctors in our department. So we were quite a big team. Other places that have run virtual hospitals have managed them from the acute medicine team or with the local GP hubs. Down in Reading, they have a mixture of acute physicians and GPs running it. So look at who's available, what are your available resources, technologically speaking. The pathway is pretty crucial. You've got to have everyone in agreement with it. So it's got to be patient-centered. You've got to have clinicians who are comfortable with the parameters that you're referring, that you're managing. Management team and admin need to be able to deliver it for you. And we often forget about the so-called back office team. If you get this wrong, a very nice paper in BMJ blogs the other day from David Oliver from Reading as well, that you know, if everyone moans about NHS management, if you don't have it, the whole thing falls apart. So you really need to have your management team on board who are going to sort of do all of that so-called back office work, which becomes very front office problems if it's not done well. And then the referrers, you need to engage with the people going to be referring in. There's no point having a wonderful pathway that your A&E department thinks is completely crazy and don't refer into. We liaise quite closely with Nida Suri, our lead in A&E department, who had a lot of whose suggestion, for example, the grab bags was, you know, the little bag with what we needed in it was her suggestion, something I hadn't thought of, something we hadn't thought of. So getting your referrers on board, finding out what their problems are and what are the problems they want solved, that will engage them into your process. And you need a good escalation route. And I think we need to remember that technology doesn't replace common sense. I mean, these are all enablers connecting you with your patients. Go to the next slide, please. So I guess for me, from the technology side of things, that the use of remote patient monitoring is a big time saver, but you need to manage patient and clinician expectation. I was not sitting there at 2 o'clock in the morning looking at patient stats, and you'd be surprised the number of people who did load things up at 2, 3, 4 in the morning. But they were happy with the reassurance that came at 9 o'clock in the morning when it was all acknowledged. And they got a message saying it had all been acknowledged. Work with what you have locally, liaise with your IT team. So we started off with a glorified Excel sheet that had multiple people accessing it on a shared drive. I look back at that now, and it wasn't actually that bad. I thought it worked quite well, but it was very low tech. We used the temper dots, which were as low tech as you can get from a digital perspective, because that's what worked, because we couldn't get hold of thermometers. And keep it all patient centered and keep it clinical, and the technology should be about making things easier. If it makes it harder, just dump it, because that's not the idea. Can we go to the next slide, please? Okay, so I think that's my signal to be quiet.
Matthew, thank you. That was terrific. And we'll be going into questions very shortly. So just a reminder, do put any questions within the chat and we'll get to as many as possible. We're really keen that you've got everything to take away if you want to set up a virtual ward yourself today. So please don't leave with any questions that we could help with. Just to reintroduce myself in case you've joined partway through, I'm Tara Donnelly and I'm the Chief Digital Officer at NHSX. And I'm just going to finish off by talking about some of the resources we have available. I'm actually quite happy to talk without the slide, and we'll just bring that up at the end. Thanks, Jenny. So today we're focusing very much on secondary care, and this model works equally well in primary care hot hubs, which is the focus of our next episode on the 22nd of September. The model that has been described is now in use across 8 sites and has looked after 270 patients. With very, very low mortality rate. We've only actually had 1 death in the cohort, which is brilliant. And as well as this work that we've been coordinating across NHSX, there's terrific work going across the country. We've had references to the Berkshire work. There's also a great service at Southampton. And we're just all keen to learn from each other and help people who want to adopt. Because we really believe this is a model that should scale. And as Alex just mentioned, while it works very well for patients with COVID, its application to other long-term conditions is very obvious as well. So we and the feedback from both patients and clinicians about how helpful they find it is really reassuring. So I'd like to highlight 2 areas of support that are available. One is the Innovation Collaborative, which is referenced on the slide there. And this is an online collaboration community, really. The email address is there at the bottom, and we can also add it in the chat as well if that's easier. And here you'll find further information from people who have done work like this, case studies, blogs, films. We're recording today's webinar. We will be posting it there as well as sending it round to everybody on the call by the end of the week. And more resources will be added there. We want it to be the most practical place for adopters to share things that can make the journey swifter and more easily achieved. And to be really practical. And if you've got great work that you'd like to share, please do let us know. We will gladly add it. And we've established a small team in support of this, of which Chris Richmond is the founder member, who you'll hear from in response to the questions, working with Breed and Tim to really help support others who'd like to do this work. And then the second thing that we've done is that we are undertaking an open procurement process to make it easier to select a digital platform that could be suitable in your area. It will make it hugely simpler for NHS organisations and those in social care who'd like to select, because the process that you need to run could typically take 3 weeks as opposed to over 3 months. So that process is almost at its conclusion and we'll be announcing really shortly, but hopefully taking away some of the procurement hurdles will really help scale of this type of work across the NHS. And that's it for me, and we'll go now into questions. It's great to see a number coming through. I've answered a couple, for example, about the recordings. Oh, many thanks to Jo from Oxford AHSN. She's been really helpfully posting links to the documents that Matthew's mentioned. So if we start with Benita Keynes, Thanks for a great talk. Have you seen any signal in heart rate as an early indicator of deterioration? So that's one for Matthew and Alex, I think.
Hi, Benita. Thanks for your question. And you're based up in Manchester, if I remember correctly. I'm pretty sure I read one of your early articles in the college journal. No, not for COVID per se. We've looked at data from about 1,400 or so COVID patients in our cohort, and we've looked at the 900 in the virtual hospital, and heart rate per se was not a predictor of deterioration other than for those that had some secondary pathology. So clearly on an individual patient basis, it prompted the reassessment of patients for pulmonary embolism, which we didn't find any in this group, but certainly secondary bacterial pneumonia was a common complication. And so both yes and no, but not just in the pure COVID patients. No, we didn't see that. We deteriorated saturations, respiratory rate, and the normal sort of elevated BMI and previous medical histories were all sort of predictors. But saturations for us was the saturations for us was the single biggest marker of the deteriorating patient in the COVID virtual hospital.
Great. And what about, were the vitals manually uploaded or Bluetooth connected to the app?
They were manually uploaded. From the point of view of saturations, the pulse could be taken from the app or could be taken from the SATS probe.
And early on, Eva Trukanowicz asked a question which I think you've already answered in part, that the schedule of phone calls changed quite dramatically once the tech was introduced.
Alex, do you want to take that one?
Can I just come in on the Bluetooth connected?
Sure.
Please, Tara. We rolled this out at pace, and Matthew and the team had already purchased a number of pulse oximeters. So obviously the fact that we could have had Bluetooth connectivity, the app does support Bluetooth connectivity, but there's a significant price differential between Bluetooth connected pulse oximeters and the manual ones with no improved efficacy. Basically, it just makes it easier for those using it. So the ability to do that was there. It wasn't used for mainly down to cost and availability of pulse oximeters at that time. There are benefits to Bluetooth connectivity. There are disadvantages to Bluetooth activity, but they weren't currently used at that time. And so pretty much most of the apps out there who do this type of remote monitoring do support Bluetooth connectivity, but it's just as easy sometimes just to enter it manually.
Great. So just to be super clear, patients would take their pulse oximetry, they would tap in the numbers into the app as they were doing their other symptom checking. That would go immediately across to the virtual ward team, who would respond accordingly. And we've got a number of examples, as Matthew has described, of that escalation happening very, very dramatically and quickly, much more quickly than the kind of routine phone calls might have reached. And then that feeds into the nice trend data that we saw. Because I think, Matthew, you're also saying that there was a manual, before using the app, there was a manual tracking of people's pulse oximetry results. Another question about just practically, how do patients return the SATS probes that the NHS issues them?
They're present. We didn't want them back because it cost us more to get them back and clean them than it cost us, even the ones we paid for. And I mean, my personal opinion is that every household should have a thermometer and a SATS probe in the first aid kit in the bathroom cupboard. So we gave out a lot. That may not be a sustainable countrywide picture. For wave 2, our local GPs had the Red Cross volunteers going around dropping them off and picking them up a week later in special sort of sealed bags.
We've kept a register of the 1,500 just in case. I've had physiologists doing 80-kilometre cycles to drop oximeters through people's doors, avoid COVID-infected cups of tea. But yeah, we would say with a gift for now.
So be good to cover a couple more questions before we need to finish. Could we, the question about that, how does the handover to primary care work, would be good. And then just to tee you up, one about user feedback. And I don't know, Lisa, maybe you could come in and just do a quick ref to the evaluation for that. But let's do those two and see how we go. So handover to primary care first.
So we, in discussion with our local CCG and myself and Andy Barlow, Director of Medicine, were on twice-weekly calls with our local CCG. We elected to continue the management of all of the patients both during their acute and post-acute COVID episodes and to do all of the follow-up for chronic COVID. The other side of that coin was that anything that was not sort of COVID related, so it's been quite a while since I've managed anything other than acute diabetic related issues, the GPs would pick up very, very quickly. So that was the sort of the deal we came to. So we handed over insofar as when we discharged the patient, they went back with a full discharge letter. But of the 1,500 or so patients, most of those patients are still under the secondary care team's care at the moment.
Terrific. And on evaluation, Lisa?
Yeah, they're very happy to comment. So just to say a little bit more about the scope of the evaluation. So we're really keen to make sure that, given this was a new area, that we evaluated it thoroughly, and we were looking for a number of areas. Certainly patient experience, which has been really positive throughout. We're also looking at ease of use from a clinician's point of view. So what we've seen and what Matthew's described is an extended use of virtual ward and really large virtual wards in the community. And of course, if that is the case, it sometimes gets really difficult to track people, but really important that those people are tracked. So we're looking for ease of use and whether this is making the working life and that type of remote monitoring easier. And then we're looking for the normal use of resources elements, such as was the patient readmitted, and Matthew's gone through all the details of that, and what the outcomes of what happened to patients and some of those clinical indicators. So that evaluation will be completed by the end of September, and we've got quite a substantial amount of data now as this piece of work started on the 23rd of April. So from that point onwards, we were using the digital platform, although Matthew has been and Alex have been using this type of clinical intervention for some time, so we do have a before and after. So that's the scope of the evaluation.
Terrific, that's great. And a very helpful addition in the chat is that a large number of pulse oximeters have been purchased for the NHS through NHS at Home, and there's a way to request them, and the email address has gone up in the link for CCGs and PCNs who would like to make use of them for care home residents or people at home in this sort of programme. So please do follow that up. I think that's probably going to take us to the end of the questions that we can answer right now. We will make sure that we document answers to all the rest and post them on the collaboration space. Chris has kindly in the chat put the email address if you'd like to join that platform. We would love to have as many people as possible and build a really vibrant community of people who would love to put the exciting work that Matthew has described into practice locally. So to close, I'd just like to say a huge thanks to Matthew and Alex, and indeed Chris and Lisa, for the session today. It's been, I think, covered the ground really very well and is super impressive. And thank you for joining us today. Please do join our innovation community online. The second episode of this programme, which focuses on primary care hot hubs, is happening on the 22nd of September. You'd be most welcome there as well. We will send the recording around today so you can share with colleagues if that's useful. So goodbye. Oh, final, one of the questions was about when will we be able to announce the procurement framework. We're just doing the final stages of evaluation of that, so it will be very soon, within the next couple of weeks. And with that, I'd like to say goodbye and best of luck in your journey on remote monitoring. Thank you.